Hello, hello, Soumya, am I audible? Hello, Soumya. Hello. Good morning. What's your email ID? Email ID? Senthilanathan94 at gmail.com. I'll type you in the message. I'm ready. Yeah. Can you just send me the email ID? Yeah. I just now sending it. Yeah. Good morning, all. Dr. Senthilanathan is on the way, means is yet to join. There's some problem since I had sent it through WhatsApp, so he was unable to join. I have resent it through the email. So please wait for 2-3 minutes. So he will join meanwhile. Madam Angeline is also there, our joint director from the Soto, Pondicherry. So welcome, madam.
Okay, I'll call you, Ashwini. I'll just call you. Hello?
Hello.
Hello? Dr. Vishnu? Am I audible, Dr. Vishnu? Hello?
Hello. I have sent that.
Yeah. Now.
Yeah. Now. Yeah. Please, guys. Yeah. Thank you.
Yeah. So I'm ready. Very good afternoon to all.
So please bear with us for another 2-3 minutes.
Yeah, sure, definitely.
மட்டும் இது போட்டுருங்க கணேஷா. அப்ப நான் இதை எடுத்துன்னு உள்ள போயிட்டா எனக்கு சத்தம் வருது. எலி எல்லாம் இருக்குல்ல, நான் இது ஏன்னா இங்க சத்தம் வருது, எனக்கு காது கேட்கும்.
Welcome, Dr. Senthilanathan. So since it's already time, Let me introduce Dr. Senthilanathan. He is currently the director of GEM Hospital, Chennai. So he has done extensive work. He's also the head of the HPB unit in GEM Hospital. He's done a lot of work on chronic pancreatitis. Initially, their unit published their first paper on laparoscopic lateral pancreatic osteotomy way back in 2006. And recently in 2019, they are published in BJS Open about laparoscopic lateral pancreatic osteotomy as well as phrase procedure. And I think they have the maximum experience in laparoscopic surgery and chronic pancreatitis. And Dr. Senthilanathan has done his GA surgery, DNB from GEM Hospital, Coimbatore. And he has been heading the HPV unit for quite a long time. So I think he is the correct person to speak on this minimally invasive surgery and its changing trends. He may also give his overview and his comments on the robotic surgery in chronic pancreatitis. So over to you, Dr. Senthil.
Thank you, Dr. Vishnu Prasad. And first of all, I thank you for inviting me to this wonderful platform to share some of our experiences with our work on chronic pancreatitis. And the journey has been nothing short of fascinating one. I would say probably it's more difficult than lab people's. That's what I was made to understand, and I also probably agree to that point. So today I will take you through some of the management protocol as far as chronic pancreatitis pain management is concerned, and I'll briefly touch upon the timing of surgery, and also I will delve more on the technical aspects of laparoscopic surgery.
Which one?
Ankit, can you mute if anybody is?
Yeah. Can the admin disable the screen sharing, enable seats screen sharing, please?
Dr. Ankit, please enable. Dr. Ankit, are you there?
Sir, sorry, not there, I think, sir.
You know,
No, you have to.
yeah. Yes, I got it. So are you getting the screen?
No, not it.
Sir, it is visible, sir.
Yeah.
Yeah.
Yeah, okay, right. Right. So I will restrict to, because we do less of, in this particular procedure, robotic, I'll delve mostly on laparoscopic surgery for chronic pancreatitis. I bring greetings from GEM Hospital, Chennai. So we all know, just a minute. Chronic pancreatitis is one thing which is a chronic debilitating illness with persistent abdominal pain associated with exocrine and endocrine insufficiency. Over a period of time, there will be definitely structural, anatomical, as well as pathological changes that continues throughout the career, one's career. That's chronic pancreatitis. Specific to Indian scenario is, especially in South India, is the presence of large obstructive calculus, unlike the mass formation, which we see generally in the Western literature. So I think we in South India especially, and overall in India, we are dealing with a tropical pancreatitis with predominantly ductal disease or the side branch disease, less of mass formation, because alcohol is another thing which is mass formation. More often in tropical pancreatitis, it's more of a stone. Inflammatory mass do occur, but not to the extent what we see in the Western literature, which is traditionally associated with alcoholic pancreatitis. We should attack being surgeons. I believe all the listening audience are surgeons. Even if you are not a surgeon, I think the point is we should attack this disease early when the complications began to set in. But having said, I also underline the fact that we should not do the surgery in all patients with chronic pancreatitis, so that we should have a step-up approach in not only in chronic acute pancreatitis, but also in chronic pancreatitis. But when we feel that the time has come for surgery, the evidences that is coming off late is to attack early from surgical point of view, rather than leaving it to burnt out. And also other thing is the chance of malignancy is always more. This is my favorite slide. The aim of treatment is pain relief, whether by open surgery, endotherapy, pancreatic replacements, or laparoscopic surgery. The aim is to have pain relief. The routes may be different, the journey may be different, but ultimately the destination is pain relief. That's what we are achieving with either of any of these treatment modalities. So it all, I reiterate, it all not only depends on the available expertise, but also to the anatomical details. A large studded stone, dilated pancreatic duct, it's better in one shot we can go for a surgery rather than doing multiple sittings with endoscopic and ESWL. I think there are very many tools that are available to nail it. It's us, the surgical as well as the endoscopic community, to use those techniques prudently and wisely without any favoritism. That's again my take on the management of chronic pancreatitis. And for that, we should have a multidisciplinary team working towards patient care. And the only aim is the best and plausible as well as simple solutions for this chronic problem. As I told you, what for to intervene surgery, like in the various other facets, the endpoint or the purpose of the surgery is predominantly for pain. What we don't operate for is for diabetes and steatoria. That let me be very clear, because we do have about more than 50% of these patients have diabetes. Equal number of patients, probably slightly less, will have steatoria. And if somebody who comes to us with large stone load, but they don't have pain, only with diabetes and steatoria, then probably offering them a surgery only on those two grounds, so we don't have the evidences at the moment to say that's a standard of care. Of course, we need to intervene surgically for malignancies, no doubt. For biliary or duodenal obstructions, especially duodenal obstructions, biliary obstruction, we do have the option of stenting with metal stents, and that also have a lot of limitations and drawbacks. Symptomatic pseudocyst, yes, it requires intervention. And finally, some of the vascular complications like splenic artery aneurysm, which cannot be coiled. So these are some of the situations where we go for surgery. And as I said, early surgery results in a reduced pancreatic insufficiency, low reintervention rate, and more importantly, it produces complete long-term sustainable pain relief. To stress upon this particular early surgery, we also have the landmark ESCAPE trial, which showed that pain relief is better with surgery, is better when early surgery is offered. Not only pain relief, it is cost effective. Early surgery results in better cost effectiveness. So that's again a very mute point to ponder. You don't have to spend much on pancreatic replacements. Pancreatic replacements have a lot of cost involved in it. So early surgery not only have an advantage from the health point of view, but also from economic point of view. Coming to the surgical options, it's again like in hernia surgery, we have various options that are available to us, starting from resections to decompressions and various hybrid procedures, which involves a little bit of resection and decompression procedures. It all started with dual procedure where we do distal drainage just to onto the tail. People thought when there is a block in the proximal portion, you do the decompression, the distal end of the pancreatic duct, it will decompress. The next one, the Pusto then modified this dual procedure, did distal pancreatectomy and then anastomose to the stump of the pancreas, that is original Pusto. Modified Pusto is no distal pancreatectomy, only lateral pancreatic drainage to the lower limb of jejunum, so that it actually holds good for countries like ours where we don't see predominantly head disease. I mean, we see predominantly stones. But of late, the stone, along with the head masses and a lot of inflammatory, pathways do happen in the head that contributes to Frey's procedure. At this point in time, Frey's is the gold standard for managing chronic pancreatitis, be it surgically by either open, laparoscopic, or robotic surgery. Frey's is a longitudinal pancreatic drainage along with head coring. We have other resection procedures, including the Whipple's, distal pancreatectomy, depending on the location of the predominant disease. Rarely performed procedures, at least in India, are Bager's procedure, where we divide neck transection with the head coring. This is duodenum preserving pancreatic head resections like the Bager's procedure, or the other one, less morbid, would be a Burns procedure, which is only head coring. Again, these are better suited for pancreatitis with head mass formation, so that you treat the head disease along with a drainage. Here again, not much of a lateral drainage. It's only a linear drainage that goes with these rarely performed procedures. Of course, it's in Germany. These are on Western world, especially in Europe, these are commonly performed procedures. Again, surgically wise, the better the larger the duct, better would be the outcomes, because logically you can drain them better. Of course, for small duct, we also do have Isbeki's procedure. In some hands it works, but majority of us will be hesitant to do a wedge-shaped resection of pancreas and then anastomose, because they don't really come to the result of a dilated duct. Yes, larger ducts, drainage procedures, smaller ducts, combination hybrid procedures or resection procedures will be needed. Of course, they do have poorer outcomes when compared to a better, larger drainage procedure situations. We also should take into consideration the presence of pancreatic head mass, distal bile duct obstruction, as well as suspicious of malignancy. Just a minute. What is suspicious of malignancy? One important thing is, please don't operate on acute episodes. That is very important. If there is a need for surgery, between the acute episode and the surgery, we should have at least 6 weeks interval minimum, so that the peripancreatic inflammation settles, and then we can go for the surgery. No peripancreatic inflammation, that will give a better surgical results, especially immediate post-operative complications are less. We are worried about the bleeding. So the second thing is surgery-wise, if you do it in acute episode, because of inflammation, identifying structures will be difficult. So, like in acute cholecystitis, better to avoid. In acute cholecystitis, we can operate on the safe period, but in such situations like in pancreatitis, for chronic pancreatitis, I'm saying, it's always better to wait for 6 weeks before we operate on these patients. No more. So that is one important point. Second, pain. As far as the results, as I told you, we always do it for the pain. And if you do a good head coring along with the lateral drainage, 90% will have a long-term pain relief. That's the evidences both in laparoscopic as well as in open literature. So there is a trade-off between resection, radical resection versus less radical resections. So the thumb rule is more resection, more pain relief, but there will be certain degree of complications, including exocrine and endocrine deficiencies. So putting together resection on one side, drainage on one side, I would say the middle path would be Frey's procedure, because Frey's combines the advantage of drainage, good drainage, as well as head coring. So on any given day, especially in Indian scenario, Frey's is better compared to only drainage, and it's always easy to reproduce when compared to Baker's or Burns procedure. We do have contradictory reports as far as the exocrine and endocrine functions. Some patients do improve, some patients will have equivocal results, some patients will have a worsening of the endocrine functions. So that's why I said, don't commit to the patient with regards to the exocrine and endocrine functions. We have to stress the fact that we are doing these procedures only for pain relief, not for the relief of any other symptoms like the steatoria and curing of diabetes or control of diabetes. If it's there, it's okay. If it is not there, we should take it because we are doing it for something else. Coming to the minimal access, more specific for laparoscopy for chronic pancreatitis, surprisingly, and it's understandably, we don't have much of a literature worldwide for laparoscopy, and more so for robotic surgery, because very little work is done in this particular area. One is the reason is it's very technically demanding. Few case series that do exist, and majority of the centers across the globe, they do predominantly by open approach, because the centers feel that it is the nuggling of the stone out, and also it's better that we feel with our hand to have the stone clearances done properly. Of course, in laparoscopy, we can avoid so that limitations by certain maneuvers and innovations, which I'm going to tell in my videos. Laparoscopy or minimal access surgery has some inherent limitations, like identifying all strictures. We do have tactile sensation, but they don't equate with that of a learned finger. Bidigital palpation is always better. We need to identify all strictures. Sometimes laparoscopically it may be difficult, at least in the initial stages of the one's career. So we need to, the key to proper drainage is to open out all strictures. We need to do this one, because you open out the predominantly the dilated portion and then leave certain undrained main duct or side duct, then we are going to have a suboptimal results in the form of the recurrence of pain. So this is the first thing to look for. That is, we have to open out the strictures. You can see the moment we open up, duct is either wide open, but there is a stricture. You can see pus was loculated in one of the strictural segment of the duct. So we need to open out these strictures so that we drain a proper, lateral drainage. So the routes may change, whether it's a laparoscopic, open or robotic, but nevertheless, what is constant is the surgical principles. If we could not achieve those surgical principles by laparoscopic or robotic, we have to convert it. So that's the point, moot point. Principles cannot change for the approaches. Our laparoscopic ultrasound is used for two areas. One is for identification of the pancreatic duct. Longitudinally, you have this one. And if you have any difficulty in identifying the pancreatic duct, it's the last resort. We do it at our institute. We feel it, we just see it, and then we puncture it. If all these maneuvers fail, then we get the help of laparoscopic ultrasound. The other area where laparoscopic ultrasound will be of useful is stone clearance. As I told you, we don't have the bidigital palpation for laparoscopy. Was in robotic surgery. So by laparoscopic ultrasound, especially in uncinate and in the tail of pancreas, we can use this laparoscopic ultrasound to check for the completeness of the stone clearance. So these two areas are very crucial for the success of this procedure. As I told you, we have to not only drain the main duct, but also open out the side branches. Here you can see this is, and we need to have a proper mapping preoperatively. We should know where and all the side branches got stuck. This is one area you can see. Main duct is open, but side branches, we should seek these side branches and then open it without leaving it, with the suboptimal stone clearance. So not only in main duct, but also in side duct, we need to be very careful in having this stone clearance done correctly. So adequate head coring, as I told you, head coring, and compared to LPG, the literatures in the last couple of decades have shown clearly that when we add a head coring, it produces better results, meaning modified PUS2 alone may not be enough in majority of the cases. Even in our center, previously we selected our cases, but here we add even at least a little bit of head coring, even if there are no mass formation in the head. So laparoscopic, one another limitations they say is not adequate head coring. But here with our technique, this is pre-coagulation of the transection plane, or the where we have to divide. It's a slicing of the head in small increments. You can see we pre-coagulate. The head area is surrounded by duodenopancreatic arcades. No named vessels though, but there are multiple arcades which can sometimes bleed, especially in laparoscopic surgery. In open surgery, you just keep a compression bidigital cocker, just do a cocker maneuver, put the hand behind the duodenum and the thumb with a gauze space, you can able to easily control. But in laparoscopy, sometimes it's difficult. So prevention is better. That means you coagulate the structures and then divide it. What we do is, with the Maryland type of bipolar forceps, we coagulate nicely the area where we wanted to do the slicing of the pancreatic tissue. Then you take the harmonic scalpel and then slice it. So that means the tissues are already coagulated before we divide. And even ultrasonic shears can sometimes may not coagulate all the things. So we have to depend on the bipolar forceps to coagulate all these structures. So this is, we can go all the way up to the anterior wall of the duct, so that the entire anterior component of the duct can, head can be cored. So head coring can also be definitely possible to the extent, there is a slight difference. I'll tell in my literature evidences what is called the modified phase. We don't need a long anastomosis. It's a long suture, arduous task, but of late, with the availability of this bobbed suturing, the suturings have suture in laparoscopy have become easy. because of the barbed. It's a single layer anastomosis, no for the two-layered anastomosis, because the barbed sutures, they get retained, have a secure a through and through property, so that we can be used to overcome the tiring journey of a long anastomosis. Coming to some of the scenarios, if it's a small duct, say less than 6 millimeters, and if you are a beginner, please proceed with open surgery. Laparoscopy may not be good, especially in the initial stage of one's career. But at the same time, and also pseudocyst, some of the complicating scenarios like pseudocyst, where you need to have an adequate drainage, we can go for open surgery. In experienced hands, yes, pseudocyst and drainage of that can be done even in laparoscopy. But initial stages, please don't select these kind of tough ones. What is adequate is, you can see the other thing area is entire pancreas replaced by stones with lot of side duct stones. And please also bear in mind that all the what's so-called as pancreatic parenchyma stones are basically side branches stones. So if you need to have lot of head coring, tail coring, the entire side branch clearance like the one which you have seen here, then probably it also is better dealt with by open surgery. Malignancies. Here, in this particular scenario, you see surrounding the stone, there is an ill-defined hypo-enhancing lesion that is a mass.
Cardio has disappeared. And I'm unable to hear.
Yes, sir. The audio is not coming, sir.
Yeah. Hello.
I power. I just connected.
Yeah. Okay. There's some power cut, it seems. Kindly bear with us. There is some cut on the Dr. Senthilanathan side. So is reconnecting. So doing this laparoscopically, post-os procedure or phrase procedure is quite a difficult task because of the bleeding that occurs. We have tried many times, but we could do successfully only in the recent past, that too robotically. Laparoscopically was really an Herculean task. So the suturing was aided by the robotic approach. So last week only we could do it successfully. Right? I think they have got the biggest experience of laparoscopic surgery. They published in 2006 the first 15 case report, and now in 2019, so 35 or 52 cases, including phrase procedure, they have published in BJ's Open.
Hello.
Hello.
Yeah, just a computer is rebooting.
Yeah.
Somehow it went suddenly out. So as it reboots, I can take probably a few questions if you have any before we are going for the video. We are going for the video. So
Yeah. When you were off, I was just telling people who are here, many of our faculty and presidents are there, and one or two our alumni are also there.
Oh, okay, right.
So I was telling that we tried initially when we tried the laparoscopic pancreaticojejunostomy, we had to convert initially because of the bleeding, but in the last few weeks only we could do it robotically.
Okay.
So because of the help of the robotic platform, we are able to do it successfully. Earlier, it was usually a conversion either at the beginning or at the end. So now only because of the advanced platform, we are able to do it. So
Yeah.
we were wondering how you could overcome this problem of bleeding, especially in those who are having some amount of portal hypertension. And if there is obstruction, associated obstruction like a biliary obstruction, how will you, was there a need for conversion or you could manage it? So those are the
I have a video which shows we combine biliary obstruction with biliary drainage, hepaticojejunostomy in the same limb. Or we can open up, better to not to open up within the phrase cord out head. It's always better to do the anastomosis separately so that can be combined. There are two options. One, you can take a separate rule limb, or we can always go, other than the same limb can also be used to do a biliary decompression also. The only thing is we should exclude malignancies. Sometimes we miss. We have to do all sorts of imaging and other bloods to exclude malignancies. So that's one important point we need to take into consideration. CA99, if need EUS and FDG PET, all these things, and also a clinical foresightedness into it. Sometimes even if all these things are negative, if feel that the terminal CBD stricture is because of, or intrapancreatic stricture is because of malignancies, then we should go for resection. Having ruled out fairly by all means, then we can go for the drainage of biliary as well as pancreatic duct in one go. So the problem is not the biliary and the by biliary obstruction all with the coexisting chronic pancreatitis. The problem is the portal hypertension. You rightly said, portal hypertension is a problem. So that my take is go slow. The most of these varices, they do happen at two places. One, in gastrocolic omentum. Divide the gastrocolic omentum safely. The second area is on the head of the pancreas. Unnamed vessels will be there, but more commonly, gastroepiploic vessels have to be tackled in the head. Sometimes it can torrentially bleed. So these are the two areas. Other than this, yes, there will be a lot of. I just connected. Can you just? I'll connect it in the.
Yeah, sure. Please go ahead. Yeah, screen is visible. Yeah, screen is visible.
Am I audible?
Yeah, you're audible.
Hello, sir.
Yeah, you're audible. Go ahead, please go ahead.
Yeah. Okay. Okay. Coexisting malignancies, I think there should not be coexisting malignancies, as you all know. As far as startup is concerned, starting is concerned, it's not a good option to start. It was not a good option to start. As you can see, well-known surgeons like Fernandez de Cruz and Michel Garnier said that there is no benefit with with laparoscopy for chronic pancreatitis. I totally agree. In 1997 and early 2000, there were not much of a training, expertise were not available, and the resources were not great in those times. So obviously, the results were not going to be very great. So, but with the constant innovations and a lot of case selection, you can see slowly we have made inroads into the chronic pancreatitis arena. So here you can see a scenario where the stones, there is no head mass, only it's atrophied pancreas, and you can see multiple stones in the duct, no side of the stones, no head mass. This is ideal for selected modified fused procedure. Second scenario is you see a headstone predominant patient, and that will always be associated small inflammation surrounding this, so that it's always better to have a phrase attached to this procedure. LPJ alone, pancreatic jejunostomy alone, may not be enough. Coming to the technical aspect, the surgeon stands between the legs. We put the camera supraumbilical. Sometimes we will not be able to reach it. Either supraumbilical applicus, parietal working locus, epigastric subsequent locus for retracting the stomach, and finally lateral locus for retraction. This is a constant port placement for majority of the pancreatic surgeries. The rate limiting step for pancreatic, the lateral pancreatic jejunostomy is the PD identification. Larger duct, wider duct, it's not a problem. Sometimes atrophic pancreatitis, you can see the difference between the parenchyma and the surface of pancreatic duct. So that you can sort of see and feel and hit. That is not working. Mapping sometimes like anteriorly, posteriorly, superficially placed thing, and then with the idea we can hit the surface of the pancreas to jet out the fluid. Other thing is superior and inferior border of pancreas have to be delineated to have an idea where the duct and is and where we can sometimes hit. If especially we are dealing with idea is sometimes we do superior because inferior is sometimes we miss the target. So superior, not only the entire head and the body should be exposed nicely, and also but also delineate the superior and inferior margin. And as I said before, lap ultrasound in case of difficulty. Stone clearance. It's the crucial portion of the entire process that we should not leave any stone undeveloped. We should really pull out the stone, clear out the side branches as far as possible. You can't coding whether it is in the head product, which is strongly. Sometimes we can also add a coding on the tail, which is also being described in the literature. Unfortunately, we cannot palpate for the stone, but with the help of laparoscopic ultrasound, with the help of instrument tip, we can sometimes feel the stone also. As it, I'll start with the stone clearance. So this is again with the stricture. You have seen the video, lots of the stone. You can see 3 instruments are being. One has retracting what is common and left hand is constantly sucking the fluid with the blood. The right hand is using it. Sometimes it can be under it's a long-standing one. Be very patient. More adequate traction should be used. More high traction should be used. Second thing is that a lot of stones getting stuck onto that. That's the trick. The trick is to identify and then open the duct. That is very important. See, sometimes we try to remove the stone through a narrow opened duct, whether it is a side branch or a main branch. So some it may not come. The mouth may be small. In such situations, we need to open up. I'll just show you. Here, this is what I'm doing. I'm opening the widening the back opening so that the spoon can be will also. It's always a short shot in the first row that we open the duct nicely, as you can see. If the opening is okay, then we go for a stone. Always have suction, whether by yourself or by the assistant, so that you have a proper roadmap as well as a clean operating field, so that you can give.
I think there's some problem with the audio, I think. There's some problem with the audio. Is it the same for all? Dr. Abhinay?
Yes, sir. It's echoing, sir. And sometimes the audio is low, sir. Yes, it's echoing, sir. And the audio is low, sir.
Is it okay now? Is it okay?
No, sir. It's the same, sir. No, sir. It's the same, sir.
The directions are broadband only. Is it okay now or still? Okay, what I will do, I will close my video.
Better,
That's
sir.
another option.
Now it is better.
Yeah, is it okay now?
Yeah. Better now.
Yeah, yes, I will close the video. So with this, I show a couple of videos. One is a straightforward phrase procedure. The other one is phrase with a biliary obstruction, which requiring hepatocogenostomy.
Laparoscopic phrase procedure.
So am I audible? No.
Yeah. Audible.
Hello.
Yeah, you're audible.
So this there is some problem. So I'll start my first video. This is a routine. You can see predominantly head disease. So this is, you can see multiple dilated ducts. We talk this is common for laparoscopy as well as for robotic surgery. This is especially after we started using robotic surgery. We are now using this one, that is tucking the structures onto the anteroabdominal wall, in the structures to the anteroabdominal wall without the need for any assistant. So this is exposing the head of pancreas after entering into the left side completely. This is what I said, expose the superior as well as inferior part of the pancreas nicely. And other important thing is cochlear member has to be done so that gives the proper exposure of the entire C loop of duodenum as well as the head of pancreas. That means we need to bring the colon down, cover the duodenum so that you have the entire operative field under our vision. This is exposure of, you can see this cochlear member being done. This is the same as we do it for open surgery. So I will not run down this video so that you can have a complete steps that we can appreciate. So once we do the cochlear member, as you can see, this is one of the nice steps to be done. This is, you can see, below is IBC. So now we do an extended cochlear, but we do an adequate cochlear. It always better to pack a crosspiece onto the posterior aspect of the duodenum so that the head bulges out into the operative field. This is what I said, expose the head of pancreas nicely. We have to be very careful in identifying and then dividing the gastroepiploic vessel. So then we put up a needle. Sometimes we have we can hit the in the first go, as you can see here. Slowly we open the pancreatic duct. You can see the large stone getting retrieved. We can use a combination of precoagulation and then harmonic, or we can use a ligasure depending on the situation. If it is atopic pancreas, we can use ligasure so that we can coagulate nicely and then cut it. Use compression that, as you can see, we can go fast if you have a undilated atopic pancreas. See, this is called splaying open of the pancreatic. And we can use retracting stitches, as you can see. Now we are using retracting stitches to open up. It's not only making a knee, but also revolting the pancreatic duct so that we can have a nice anastomosis. That's called splaying of pancreatic duct. Laying open of entire. I think now we can see that what you see as the vein stone in the head now has been removed. We have to go all the way. This is called echoing. This is, you can see it's a stage just being applied, and then go the pancreatic gland in small incremental stripping of the duct, sorry, the gland. We use some multiple such small bits of pancreatic headcore, as you can now we can see the entire posterior pancreatic duct mucosa is seen. That is the limit of our headcoring. Once that is done, we take a rule in a rhythmic fashion, and we suppose we open the jejunum to the length of the pancreatic duct. Don't open more. Probably if you feel that you need to open a little bit, also we can do it later, but don't open more. If it's just adequate or probably a little less, jejunum has the tendency to stretch it. Sometimes we open more and then later we have to switch it back. So don't do that. It's unwanted step. Then we start a long anastomosis. If you plan the anastomosis properly, it should get over by about 45 minutes to 40 minutes. As you can see, nicely it's coming. Some of the stage stitches we have used and help in retracting the pancreatic duct. And the assistant can retract the jejunum so that we have what inline saving anastomotic line. So that you don't struggle a bit. We may put additional, we may need to put additional profiles to do that one, but if in case there is a need, don't hesitate to put. One or two profiles extra will not reduce the shine of the mirror accesses, rather it will help you in furthering the advantages of. This is again a reverse stitch onto the head, a little difficult, carefully it has to be done, because the white shirt will be thick to accommodate the entire coat of the head. You can see nicely tied up, it's getting approximated, invaginated, that's very important, so that you have a nice tension-free pancreatico-jejunal anastomosis. This is what we see, invaginating stitches onto the pancreas. We take onto the cut surface, try to take at least about 1.5 centimeters. Even if you don't reach the back, it's okay. That is the posterior wall is okay, but at least the position of pancreatic parenchyma has to be taken. This principle is the same as in open surgery also. Generally, we restrict to one layer, especially the bob sutures. This is two previous bob sutures. Even before that, we are restricted. If we have nice anastomosis, we need one anastomosis, and then jejunal anastomosis. We keep a tray. It's always better that we remove the stones in the endovac as well as the core specimen so that we don't contaminate the wound. The next video which I'm going to show is a phrase procedure along with choledocodiode jejunostomy for biliary obstruction along with chronic pancreatitis. Again, CT shows you can see dilated biliary systems. We have already stated that one, reduce the bilirubin, make sure that there is no malignancy associated with it, and then we proceeded with phrase procedure along with the biliary bypass. So I start directly with the cock-up. So very important, the same steps should be done for all patients. So why sometimes there will be patients, there will be port liposuction. We have to be very careful. This is right gastric point. It is one vessel, okay, is a lot of times forgotten. Sometimes we'll have a problem. So exposure is done. When I use a laparoscopic ultrasound, we have a marking. We can see clearly the lower border nicely delineated, so that we go back to it. So once that is done, we generally we use hook because it gives a nice fine entry into the duct. So once this is done, after the entry, it's all clear. You can see we can go all the way up to the tail of pancreas, about 1.5 centimeter in the tail. This is the head predominant disease. So you can see the stones are jetting out from the head predominantly. We go and then remove as soon as possible all the stones. We continue our head boning well into the head as well as unsafe process. Pre-coagulated structures, these cannot be violated. And you can see stones. We have to go all the way up to the antler, and then we need to put a small feed tube into the duct that should get out into the antler. That's the complete stone clearance. So now head coating is done. You can see after that we go for this patient has got all the stones. So cholecystectomy is done. Expose the, you can see dilated duct. While it is nicely dilated. We can use ICG also in these scenarios, so that it will give a nice roadmap better than the routine conventional one. Then we go for creation of ruling. And here, a ruling has to be created so that it reaches the tail of pancreas with dedication. Generally, our philosophy is to go on to the right side of the middle colon, but there are surgeons, other techniques you can also go on to the left side of the middle colon. This will avoid kinking, we believe. This has got a nice curvature without acute kinking. But the only thing is that the center has to be divided more to accommodate that it should build onto the left side, that is the tail of pancreas. Again, we open just adequately to feed it onto the open pancreatic duct. This is the first corner bite. Don't miss out the corners, that's very important. We should never miss out the corners. We can see the mucosa to mucosa anastomosis is preferable. May not be possible in the head, that's okay, but as far as possible, try to approximate the duct to mucosa. So this is anterior, no starting posteriorly, and then come anteriorly. It's a long, pretty long anastomosis. Head, as I told you, have to be very careful. Sometimes you may hit the vessel. Here I'm taking careful bites, not to avoid hitting the right epigastric vessel. Take a long needle, that's very important. Don't at least use 35 millimeter needle, not other 25, 28 millimeter, not be enough. So this is to show that we can reinforce if you are not sure, or if you want to do those are believers of full-aid anastomosis, you can reinforce with the cerebromuscular bites. This is the fourth layer that we do. And it's always good practice that the duodenum of the tissue should be lying each other. That is, anastomosis is well set, no tension. That is the proper, way of doing it. Then we go for really drainage. You can see we open out the initially with this, the bacteria with the bone scissors, so that you don't lose the vascularity. We go between the 9 o'clock and 3 o'clock orbit, remove the stent to spray place 3 orbit. And then the anastomosis here, we use 4 OPDs. For pancreatic anastomosis, it is 2 OPDs. Here, this is of OPS, so that the ulcer is predominantly in monofilament structures. Posterior layer first. We can use a continuous. Now our preference is to use a continuous layer. So here you can see that after finishing the posterior layer, we are coming to the anterior layer. Corners are secure. So this is the same lady. As the only alternate option is to use second rolling. But that ladder to our low anastomosis, it will consume some more of the region. So that it's our preference. There is not much of difference between single rolling and dual rolling. And then we complete with the judicial anastomosis. So these are a couple of videos I want to show. One with a straightforward phrase, the other one is with biliary obstructions. So not much of literature support for laparoscopy or for robotic surgery. Only as you can see, there are hardly few articles for robotic surgery because of the technical demanding. And when Dr. Vishnu said that he found it difficult in initial stages, I totally agree and then feel what are his feelings, because it will be difficult to overcome the learning curve. But I can assure, with proper case selection, once you overcome that one, you will be loving this procedure. Even you can see, only 10 years back, we had the first UK experiences, and you see there were hardly few cases that's been reported in the literature. This was the first article which Dr. Vishnu Prasad has quoted. This we got published. Again, our very initial experiences with 12 patients. And you see the mean diameter. Now we are operating on 5-6 millimeter by laparoscopy or robotic. But the initial stages, you see, this is how, when Michel Gagnier attempted by laparoscopic surgery, the results were not all that great. That is because of the improper case selections. We used a hugely dilated duct as our initial learning curve patients. Then you can see complete pain relief was achieved in close to 85% of patients. This is our second article, which dealt with long-term pain relief for both LPG as well as for pain phrase procedure. And what is this? I wanted to say modified phrase operation. Modified phrase, by which we mean we clear the pancreatic parenchyma anterior to the main pancreatic duct, because we feel it's very risky and it's not controlled environment to go posterior to the pancreatic duct. If any duct stones which are left in the side branches posterior to the pancreatic duct, we do by open approach, because the limit is obviously posterior pancreatic capsule, but we cannot go that far in laparoscopy. We should have a roadmap. We should have tactile feedback onto the posterior side. That is not there with open both robotic as well as laparoscopic approach. So for safety purpose, we restrict our head coring to anterior to the duct. We don't go posterior. That is called modified phrase operation. By this definition, almost 85 to 90% of people can qualify for laparoscopic surgery. In case, if you could see a lot of headstones which extends well into the uncinate, well posterior to the pancreatic duct, then on our preference is open approach. So these were the variables. Age, this was compared to our laparoscopic as well as laparoscopic phrase and laparoscopic LPJ, so that both have a comparable outcome. Follow-up is also good. You can see 58 months in LPJ and phrase procedure 46 months, because our initial experiences were full of LPJ, and later on we know the technical know-how of phrase procedure, and now it's almost 100% that we are following phrase procedure. What's important is the pain, the pain relief. You can see long-term pain relief is in laparoscopic phrase procedure is about close to 90%. So this is definitely not inferior to open. Any procedure which has got a long-term pain relief of about 90% should be considered as a standard of care. This is what our comparative study with the rest of the open literature have shown. Here we have our results of 47 patients with reasonable blood loss, good operative, reasonable comparable operative time, with a few morbidity profile. Hospital stay is also good. And what we have is you can see pain relief, 85% long-term pain relief. And you look at the various other open literature, starting from Frey to Isbeki to other studies across the globe, the pain relief is definitely comparable. Weight gain, so as the weight gain as well as the other parameters are concerned. So definitely it's a procedure to be reckoned with the added advantage of minimal access surgery. We also do have studies from Mumbai, which also shown that 62 patients. Here again, they also had a mixture of LPG and Frey, more of an LPG with a 10-year experience. They also showed that a good long-term pain control with the laparoscopic approaches. This is the second Indian study which has got a long. Another study from Om Tantia group from Kolkata also shown that the pain control is good. There are other new developments not related to talk, but I also wanted you to ponder over, like the total pancreatectomy with islet cell transplant. We also published single incision laparoscopic pancreatic jejunostomy just to demonstrate that technically everything is feasible. This we published in the Pancreatology journal about a decade back, which showed that this is one of the people who say that the anastomosis is difficult, long anastomosis, difficult to do by laparoscopic or robotic. Here is an answer that we can even do when somebody can do it by single incision with a crowding of instruments. Why can't we do it by laparoscopic or open? So in the interest of time, I'll close it. My closing remarks would be laparoscopy for chronic pancreatitis, definitely, or I can also, I skipped robotic part because hardly few literature, but nevertheless, both are the same with, I would say, one advantage and one disadvantage. The advantage is the anastomosis. Sometimes we do a laparoscopic resection of Whipple's and then the robotic reconstruction on thin undilated duct. Likewise, it's a long anastomosis. Anastomosis is better by robotic. Dr. Vishnu will also agree. The only thing is that the tactile feedback is not there. We all stress on tactile feedback. In open, we had a little bit of that one being hampered in laparoscopy. In robotic surgery, that we have gone little further also. We can able to feel a sort of feel with experience, but nevertheless, with robotic surgery, the touch and feel is not there. So that's the only drawback. Otherwise, put it all together, definitely in selected patients, whether laparoscopic or robotic surgery can be done, so that we can give the benefit of minimal access surgery. Even in complicated scenarios like head mass, portal hypertension, or biliary obstruction, definitely it has shown equal results with a better, equal long-term pain relief scores when compared to open surgery. So that's my take. I also take this opportunity to invite you all to the hernia carnival, which is happening. If you're hardcore HPB surgeons, you can afford to miss. But if you're general surgeons or surgical gastroenterologist, you also do quite a bit of hernia by laparoscopic or robotic surgery. I invite you for this hernia carnival. which showcases the best of robotic as well as laparoscopic surgery. See you there in Hernia Carnival from March 15th to 16th. So I think once again, I thank Dr. Vishnu, the entire JIPMA faculty for inviting me to this wonderful, platform to share some of my experiences.
Oh, thank you.
I
Dr.
sorry, I overshoot time by about 10-15 minutes, and also apologies for the technical issues. Any such programs will be successful. I consider successful only if we have a good discussion. I hope to have a few minutes of discussion. Being a Sunday, I think we can afford to have additional time for us to discuss. Probably you can give some inputs so that I can learn something more.
No, your experience
Thank you
is
very much.
more than us. It was an excellent video lecture, and we have learned a lot. And we have one pancreatic surgeon in the group, Dr. Rajkumar. I think he is still there. Rajkumar, you can ask the questions, I think. So he does a lot of pancreatic surgery, including laparoscopic ripples. So Rajkumar, if you're there. So Rajkumar, if you're there. Hello.
Yes, Dr. Rajkumar.
Okay, meanwhile, I just want to ask, if you do the same surgery robotically, what will be the charges in your hospital? Just curious to know. What will be the charges in your hospital? Just curious to know.
Okay, we generally use for one arm, it's about 25,000 rupees. Sometimes we are complete with two arms. So that means with camera one arm and that arms, it will be about 75,000 rupees extra. Generally, we quote the laparoscopic and robotic charges just for the thumb rule is 1 lakh extra. Sometimes it can be 75,000. Sometimes it can be as the same as laparoscopy. So we have a center. If I wanted to do something like laparoscopic surgery, the patient is probably absorb the cost. Not in patients, but in certain patients, rare surgeries, where we feel robotic is better, then obviously a patient is not affordable. We don't really go with the patient's, financial status. So we all, I think JIPMER also can afford that one, GEM also can afford that one. So that we general, the quoted, the world, at least in India, the general recommendation is lakh rupees extra for robotic. I think some of you are doing robotic surgery can give if you are not in accordance with our policy, you can speak up.
So one more, what I feel.
Yeah, yes.
What I felt is during the robotic surgery, that bipolar instrument which we use is quite useful compared to the laparoscopic bipolar. And we are able to control the bleeding in robotic surgery using the Da Vinci Xi better than during the laparoscopy, especially during the head coring procedure or during the duct opening. So what do you feel? Is it the same with your experience? So you are able to control equally when during laparoscopy?
Yes, I'll tell, definitely I agree with you. In general, monopolar and bipolar instruments work better with robotic. There is no denying. For some reasons, probably I also asked the company. One is it's a limited usage instruments. One more it's a 10 usage instruments, and for that also open. It's multiple hundreds of usage. So the cables, everything is fresh, used for limited instruments. And the company which we use, it's RB. It is also a reputed multinational company. So adding these multiple factors, probably, I totally agree with you. Bipolar, or even I go on further and then say monopolar also works better in robotic platform rather than laparoscopy. Doesn't mean that it doesn't work better in laparoscopy, but you can see the difference in fine surgeries. Yes, if you want to pre-coagulate and then cut it, I think robotic surgery will be better. And also vision is good. 3D, we can work close. One difference of what I say is in laparoscopic surgery, sometimes it can be very close, but in robotic surgery, we can never be close. It will be adequate. Even if you are close, still it will be pleasant to work. So I would say it's like an icing on the cake. Minimal access is a cake. Icing on the cake is robotic surgery.
Thank you. So, any more questions, Dr. Uday, Devashish, Abhinay? Any more questions, Dr. Uday, Devashish, Abhinay?
Dr. Vishnu, I want to ask you, you said you had difficulty. I totally agree. Any center taking up a chronic pancreatitis program will have initial hiccups. What were your challenges so that I can teach my younger colleagues, postgraduates, about the organ centers for perception?
Initially, we were not choosy. We realized that when you start laparoscopic robotically, select cases are better. Select cases are better. If you try to take a difficult one, you end up converting. So that's what initially some of the cases we didn't select. So those are actually advanced. Some of them had mild portal hypertension, and we realized those are the cases where we couldn't control the bleeding. So we had to convert. So as we gained the experience, we thought we became very choosy. Now we select only cases where the duct is dilated, not much stone burden, easy to do. Not much stone burden, easy to do. So with that we have become successful. Otherwise, we used to convert a lot. Our conversion rate was very high. Now it is coming down.
It's a very valid point. Even now at our center, some of the cases go down, they go directly to open surgery. But this time we should have, even after say 20 years, we have been doing for more than 25 years. Still, some of them will be upfront as a data. No other findings, we immediately convert without even attempting laparoscopic or robotic. As you rightly said, those patients should go directly with all the high risk ones not amenable for minimal access. They should go directly to laparoscopy, open surgery. And my point is, in general, there will be only one attempt for surgical correction. Unlike must be 10%. But in laparoscopic, in chronic pancreatitis, you probably, if there is a pain, it will be very difficult to have a resurgery. It's very difficult, probably except for malignancies. So the first attempt is best attempt. That adage is even more valid in chronic pancreatitis than in other scenarios like hepaticojejunostomy. So we should have a proper stone clearance. And if that is people accessibility sampling, we should never hesitate to convert, never hesitate to do upfront open surgery, because we want to become manageable. In fact, I'm very passionate about chronic pancreatitis by laparoscopic surgery because that's a road less traveled, I can say, compared to, say, Whipple's, liver resections, or colectomies and esophageectomies. This one area has less papers, less literature. So I have a personal interest in chronic is about 60 to 70% by laparoscopic or robotic, and 40% even now is open surgery. I'm talking about direct upfront open surgery. Whereas in Whipple's procedure and liver resection, it's about 80% of laparoscopic surgery or minimal access surgery.
Thank you very much. That was an excellent lecture with very good comments. So if any more questions from anybody would like to ask, please ask. We'll wait for 30 seconds and then close the session. Any more questions?
Then close the session.
Okay, thank you very much. That is very kind of you to accept our invitation in such a short span of time and gave us the lecture. Thank you very much. I'm closing the session for all. Thank you.